A very good morning to one and all present here. Myself Megha and this is Dashni and Subiksha here to present the case on nervous system. Mr. Ramakrishnan, 73-year-old male who is a former driver by occupation residing in Kulashekaram, was admitted on 2nd February 2025 with complaints of weakness of right lower limb and upper limb and slurred speech for 1 day. He was carried to the hospital by his wife, who was an informant. She is reliable. History of presenting illness. The patient was apparently normal till 1 day back. 1 day ago at 6 a.m. in the morning, he woke up from sleep and brushed his teeth. 5 minutes later, while walking to the toilet, he felt difficulty in walking due to weakness of his right lower limb. He had to drag his right lower limb while walking. He was, however, able to walk on his own without any support. Over the next 2 hours, he noticed that his right upper limb was also getting weak. He had difficulty in holding objects with his right hand and difficulty in raising his hand above the shoulder. 2 hours later, he found his right-sided weakness had worsened. He fell down when he attempted to walk and needed assistance of 2% for walking. He was also unable to move his right upper limb at all. His wife noticed that there was deviation of angle of his mouth to the left and drooling of saliva from the right corner of his mouth. Wife then noticed that his speech was slurred and was not as legible as before. However, he was able to understand what was being said to him. The patient was taken to the hospital after 9 hours of onset of symptoms. No history of loss of consciousness, seizures or headache, vomiting, drowsiness or memory disturbance. There was no history of disturbance in appreciating smell or blurring of vision or disturbance in appreciating color. There was no drooping of eyelids or double vision or difficulty in moving eyeball in all directions. There was no difficulty in appreciating sensation over the face and difficulty in chewing. There was no difficulty in closing eyes, loss of taste sensation, increased sensitivity to sound or dryness of eyes. There was no hard of hearing, ringing sensation in the ear, sensation of rotation of self or surroundings. There was no nasal regurgitation or nasal twang of voice or hoarseness of voice or difficulty in swallowing. There was no difficulty in turning neck from side to side. There was no history of bowel or bladder disturbances, no sensory disturbances like loss of appreciating pain, sensation of clots, hot and cold sensation, and tingling or numbness. There was no swaying while walking or tremulousness of limbs. There was no involuntary movements, there was no chest pain, palpitation or fever, night sweats, weight loss, breathlessness or cough or hemoptysis. Past history. The patient has a history of diabetes mellitus for past 12 years and was on irregular medication. He has history of systemic hypertension for past 10 years and is on medication for the same. There is no history of previous episodes of similar illness or transient ischemic attack or coronary artery disease, epilepsy or tuberculosis. Personal history. The patient consumes mixed diet. He is not a smoker or an alcoholic. He has normal bowel and bladder movements with adequate sleep. Family history. There is history of type 2 diabetes mellitus in father and mother. There is no history of systemic hypertension, coronary artery disease or cerebrovascular accident in the family. Summary. A 73-year-old male, known diabetic and hypertensive for more than 10 years, presented with acute onset of weakness in the right lower limb and right upper limb with slurred speech and deviation of angle of mouth towards left side. History is suggestive of an acute stroke syndrome with right-sided hemiplegia, probably due to ischemic etiology.
General examination. Patient is conscious, alert and oriented to time, place and person, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymph node enlargement. Vitals, pulse rate 66 beats per minute, regular rhythm, normal volume and character, no radiofemoral delay, peripheral pulses felt with equal intensity, no vessel wall thickening, blood pressure 130/90 mm mercury, measured in left upper limb in supine position, respiratory rate 18 per minute, regular, abdominothoracic in type, temperature 98.6 degree Fahrenheit. Head to toe examination, there was presence of angle of deviation of mouth to the left side. Patient is conscious and was not moving his right upper limb and lower limb. Attitude of the patient: upper limb adducted shoulders, extended elbow and wrist, lower limb knee extended and externally rotated. No neurocutaneous markers present. Examination of nervous system. Higher mental.
Before that is important because to identify the first present the history wise, I think you presented nicely. Important point for the learning point for the other students is going to be she has covered up all the aspects of a required history for long case. She has not stopped only at the level of neurological system. She also covered up respiratory system, abdomen as well as cardiovascular, which is a part of your structure of your history taking for any long case, irrespective of the system involved, which you have done correctly. And another important point is the history is obtained from, especially from a neurological case. She mentioned about the reliability of the informant. That's very important. That also she has mentioned very nicely on that part. So what do you really want to convey at the end of the history? You mentioned about a neurological deficit or stroke syndrome. And why do you think that way? What are the points in the history to think that way?
So to begin with, the patient
Yes.
from the history, I can say that it is a.
Go to the mic.
So from the history, I can say that it's a acute onset neurological illness. And there is features of.
Any other cause for acute neurological deficit other than the vascular etiology? Anything else?
There can be acute infection in the brain. Then or
Can
any
this
tumor-
produce this type of sudden onset? While brushing, he was okay. 5 minutes or half an hour later, he was found to be difficult in using his right lower limb. So, do you expect any infection can produce this type of changes?
it can,
Usually, it doesn't happen that way, that rapid. Okay, yes.
any tumor compressing.
What complication can happen
Yeah.
in a tumor? Already there is a tumor. Any complication can happen in tumor suddenly.
Hemorrhagic manifestation,
Bleeding into the tumor.
bleeding into the tumor.
Bleeding to the tumor. Tumor is static one. It's a long-term process. It will not produce acute stroke of this nature. It can produce sudden neurological deficit. There's a bleeding into the tumor. Okay. Then anything else? I'm saying it is nothing to do with the problem of your vascular territory. Anything else? Sudden neurological deficits. Focal, generalized. What? No. Vascular. Talking about deficit is confirmed. Patient whatever the
Can be
experience.
due to a trauma.
What are the stroke mimickers? Then Todd Span's post-ictal status. So metabolic causes also can be thought about as a presentation as a deficit. This point I want to highlight here is not only the vascular territory but also can be stroke mimickers can be there. That point you should remember. It is not truly applicable into your patient now, this point of junction. But even you should think about stroke mimickers also, the point take home point at this point of time. Okay? So where do you think that problem you are dealing with? Already sir was mentioning about nicely on the localization of the neurological deficit. Recollecting that and try to apply that knowledge here where you want to fix the problem at this point of time. Not only the presenter can attempt, others also can attempt.
It is a motor deficit basically.
Okay.
Only motor features are there. And there is involvement of both upper limb and lower limb. Mostly equal.
Gradually started from lower limb to the upper limb, then face it, speech involvement, right? This is what your description is saying. Okay.
Is it uniformly affected or one more than the other?
It is uniform, sir.
Upper limb. Sometimes people say there's only minimal weakness of the upper limb, but lower limb is very much affected. Then there's a disparity. So you have to see whether there's a disparity in weakness or it is equally affected. Here also it is equally affected.
Equally affected.
Exact grade you can tell only after examination. Whether it is grade 0, 1, 2, tell only after examination. From history you can say whether there is a disparity or not. If there is a disparity, it is a clue about cortical lesion.
Cortical lesions.
Do you think I will deal with the cortical disease here?
No, sir. Because on examining. Okay.
No. History wise. There's a lower limb, upper limb speech difficulty also is there.
Speech difficulty is there, so I can suspect a cortical lesion. But on examination, I'll further see the components of speech and decide whether it's aphasia or dysarthria, and then rule out cortical lesion.
So do you think they will be dealing with any problem at the brainstem level?
Yes, sir, because cranial, I suspect facial nerve injury, so there can
Facial
be
involvement.
So,
This facial nerve is on the same side of weakness or opposite of weakness from your eyes? What do you think? Is deviation about towards left side? That is what your deviation of angle of towards left side means there is right facial pulse. Hemiplea also on the right side.
Same.
So it is same side. So it is possible, brainstem possible or less likely?
less
Less
likely.
likely because it is not crossed.
Before moving on to that and finalizing that, you try to think about brainstem and cortex. Brainstem, there are points against from the history point of view, and cortex also possibilities are there but not fixed. You can definitely fix the disease, major disease at the internal capsule. So try to fix an idea about how to localize the disease. That's a basic point I want to highlight here.
Suppose it is a right hemiplane. I am saying it is a left condylation goes in right hemiplane. What are the events you expect? I am saying it is a left condylation and that goes right hemiplane. What are the events you expect?
There will be same left side element type of
The element
correlation.
person left side. One more current enough. Because it is pons. Any other current or pons? The left 6 can be. So in the symptom, what will be the symptom report?
Facial rectus pulse.
So what is symptom? Patient will not say I have left rectus pulse. He will report only a symptom.
He will not be able to see the.
One muscle is affected, not at all
What
going.
will be the symptom of lateral rectus pulse? Squint is a sign, symptom.
Yes.
Double vision, single vision, especially looking to left side. Affected muscle direction moving and double vision. Left lateral means whenever it tries to look to the left, there is double vision. You will say there is horizontal separation of images.
Yes. I think this point of time I try to have the summary. Before that, try to include all the other system related questions and try to have an idea about am I dealing with conventionally at the undergraduate level. You're going to try to fix the disease internal capsule. Commonest problem which you're going to keep for the examination is concerned. But even then, try to think about the context or lower level by the ways of looking at the clinical features from the history point of view. That's the point you want to highlight here. Think about that and try to rule out. Because you're anticipating the questions from the examiner, only those two areas. And you're going to settle down for internal capsule. But you should know the features for the lower part and the upper part of your brain. Okay? Yes.
Suppose patient has a cough, hemoptysis, weight loss, what is the relevance in this 73-year-old male? Smoker, is a smoker?
No, sir, he's not a smoker.
Suppose it's a 73-year-old male smoker and complaining of weight loss of hemoptysis.
Metastasis.
Then because the underlying problem is lung cancer and hemiplea due to metastasis. Suppose there's a cardiac patient, palpitation, breathlessness, then it could be atrial. That is why you do. That's called review of systems. You look whether symptoms are there in other systems also. You have already done. Suppose young female, 20-year-old, having recurrent episodes of stroke. She is saying 6 months back or so, I had similar episode. 3 months back, I had a vision loss. And this is the third episode. 20-year-old female, what other condition do you suspect? Like European. Autoimmune, any specific name of the disease? SL, more common, much more neurologically related. Other than vascular, any other neurological? Young female. Demyelination. Multiple sclerosis can cause episodes. Typical description of multiple sclerosis episodes that is disseminated in time and space. What do you mean by the statement disseminated in time and space? Episodes occur in different time and space. Site also varies. One time it is internal capsule, another time cortex, next time it will be optic nerve. So you get multiple episodes of neurological lesions. In the young patient, it could be multiple sclerosis. This is not the age group of multiple sclerosis.
Examination of nervous system, higher mental function. Patient is right-handed. Education status is studied up to 5th standard. Conscious, oriented to time, place, person. He is alert and attentive. His memory is intact. Speech, presence of dysarthria. Intelligence normal. Behavior and emotional status normal. Appearance well-groomed. No delusions and hallucinations. Cranial nerve examination.
Speech you can mention that naming and other aspects are normal, you should specifically mention. When you write a case sheet in speech column, you have to tell naming, fluency, comprehension, etc. either normal or abnormal.
Olfactory nerve, able to perceive smell on both sides. Optic nerve, visual acuity 6/6 on both eyes. Visual field bilaterally normal. Color vision bilaterally normal. Cranial nerve, 3rd, 4th and 6th, oculomotor, trochlear and abducens. Lid retraction, ptosis, squint, bilaterally absent. Extraocular movements normal on both sides. Diplopia and nystagmus bilaterally absent. Pupil size 2 mm on both sides. Shape bilaterally round. Equality and regularity bilaterally equal and regular. Direct light reflex and indirect light reflex present. Accommodation reflex present on both sides. Trigeminal nerve, sensory component intact on both sides. Motor component, no wasting in both sides in temporalis and masseter. Pterygoid normal power. Reflex, corneal and conjunctival reflexes present. Jaw jerk absent. Facial nerve, wrinkling of forehead normal on both sides. Tight eye closure normal on both sides. Showing of teeth, deviation of angle of mouth to left side. Blowing of cheeks and whistling, absent on right side, present on left side. Nasolabial fold, obliterated on right side, present on left side. Platysma, not prominent on right side. Hyperacusis, absent on both sides. Sensory component, anterior 2/3 of tongue taste sensation, normal on both sides. Reflex, corneal and conjunctival reflexes present. Secretomotor part, salivation and lacrimation, normal. Vestibulocochlear nerve, Rennie's test positive on both sides. Weber's test equally heard on both sides. Vertigo absent on both sides. Glossopharyngeal and vagus nerve. Uvula centrally placed. Gag reflex and palatal reflex present. Spinal accessory nerve. Shrugging of shoulders and turning head again resistance were present on both sides. Hypoglossal nerve. Tongue protrusion normal. Wasting, no wasting of tongue muscle. Power normal on both sides. Fasciculation absent.
What is the only cranial abnormality you got? Facial. Is there any other cranial abnormality possible in this case? How is it possible? Because we have said about that phase, the 3-phase, single phase. 12th nerve usually has bilateral connection. In some persons, 12th nerve has only unilateral connection. In such cases, when there is a lesion on one side, you can get opposite 12th nerve. Such cases, tongue will be deviated to one side. So you have to look for protrusion of the tongue. Here the tongue is normal. Suppose if tongue is deviated to one side, means that side there is paralyzed. So it is the opposite side brain lesion.
This patient, you mentioned about the deviation of the tongue to the left side and saying that right side UM facial palsy, right? That means only the lower quadrant alone is involved. Can you get element facial palsy involved only quadrant part? Usually undergraduate level, you know that half is involved. Can you get only quadrant alone can be involved in case of element facial palsy? Yes. Generally, element facial palsy on half. Only quadrant is involved, UM. Question is about can you get element in case of only quadrant alone is involved?
Five divisions, motor divisions. So affecting, depends on the affecting part, we can.
So before dividing into 5, there are 2 major divisions. That is zygomatico-temporal and cervicofacial. From there you have the zygomatic temporal part, upper labial, lower labial and cervical part. So when there is a problem at the parotid gland, that's where the division is happening. So the division area, one division alone can be involved to produce one quadrant. So there is a theoretical possibility, practical possibility of having one quadrant alone can be involved even in element. It's only additional learning point for the undergraduate. You should know generally half is element. Quadrant is UM. But can you get is additional questions raised by the examiner, you should be able to answer. When there is a local involvement at the parotid level, distal most area, divisions are involved, you can get quadrant alone will be involved. Okay, it's a parotid level involved. Yes, possibility. Yes, thank you. Yeah.
Motor system examination. Bulk. On inspection, there was no muscle wasting on both the side. Upper limb, arm weight 27 centimeter on both right and left. Forearm weight 20 centimeter on both sides. Lower limb, thighs 37 centimeter on both right and left, and leg weight 27 centimeter on both right and left. Tone, both the upper limb and lower limb had hypotonia on right side, and tone were normal in left side. Power in upper limb, on right side it was grade 0 power with hand grip, weak hand grip, and on left side it was grade 5 and normal hand grip. Lower limb on right side it was grade 0 power, and on left side it is grade 5 power. Reflexes, superficial.
So that's called dense symmetry. Suppose there is 4 minus on one and 0 on the other, means it is disparity.
Superficial reflexes. Abdominal cremasteric reflex were absent, except that all were present on right side, and plantar reflex were extensor on right side. Superficial reflex on left were normal, and abdominal and cremasteric muscles were present, and there was flexor plantar reflex. Deep reflexes, it was +1 in right side and normal on left side. Plantar and ankle clonus were absent on both the sides. Coordination and sensory system. Finger nose test, finger nose finger test, heel knee test, draw circle in air, dysdecadokinesia, rebound phenomena cannot be tested on right side and was normal on left side.
What's the tone of this patient? Go back to the tone. That is it. Tone. Hypotonia. Why do you want to mention about clonus here? Next point. To this lines, like I mentioned about clonus. Are we expecting clonus in a hypotonia patient? Actually, don't expect. Yes.
Why you get hypotonia in this case? What is the reason? Normally, what is the expected finding in UML lesion? UML lesion was spasticity and LML lesion was hypotonia. What's the explanation for hypotonia in your case? Because initial 2-3 weeks, 4 to 6 weeks patient can be in spinal shock. At that time, tone is normal. Later, when tone is increased, you get clonus.
Sensory system were intact on both the sides. Skull and spine were normal. Other system examination. Cardiovascular system, apex beat normal in position, S1, S2 heard, no added sound. Respiratory system, trachea central, bilaterally symmetrical chest, normal vesicular breath sound heard, no added sound. GIT, no organomegaly, no free fluid, normal bowel sound heard.
Peripheral pulses, pulse rate or normal, like you mentioned, peripheral pulses were present. Dorsalis, pedis, posterior, all present. Here, regular also.
Yes, sir.
Did you attempt to make a BP measurement and pulse rate measurement between the supine and the sitting posture?
No, sir. In the supine position only we did, the patient was unable to.
So what is the clinical relevance of this examination method or step in a case of neurological deficit? Due to
autonomic nervous system.
so the additional points to be included to your nervous system examination is, other than the skull and spine, you are supposed to examine for salient bedside features for autonomic involvement and peripheral nervous system involvement also. If you are going to add, that adds value to your complete pattern of examination or complete subject of examination of the neurological system. It is not only the central nervous system, what you are examining, because the first slide you mentioned about neurological system or nervous system, which includes PNS, ANS, CNS. Okay, what you have done is completely CNS part you have done it. ANS part, whatever is feasible, bedside, along with PNS. Peripheral nervous system, just try to palpate accessible peripheral nerves, look for any tenderness, any evidence of nodularity, and look for, in the hands at least, look for tinel sign. What is tinel sign?
Tingling sensation.
Now the nerve distribution by tapping or stimulating the nerve, you'll be able to get the tingling sensation. It's a sign of possibility of regeneration. Okay. So it is to be checked for any case of nervous system examination. Suppose given case is only central nervous system, acceptable. It's all a way of learning. So as a completion should include your peripheral nervous system and autonomic nervous system. Go and read about what are the points to be added for autonomic nervous system, BP and heart rate. And sweating also.
Carotid bruit, vertebral bruit, that also you can. After the sensory system, miscellaneous signs of meningeal irritation. Things you look for and miscellaneous things after the sensory system, signs of meningeal irritation, skull and spine, peripheral nerve thickenings, then carotid and vertebral bruit.
Summary: a 73-year-old gentleman, chronic diabetic and hypertensive with poor drug compliance, presented with complaints of weakness of right lower limb and upper limb, slurred speech, deviation of angle of mouth to left side for 1 day. On examination, the patient had dysarthria, involvement of facial nerve in the form of right human facial palsy, presence of hypotonia in right upper and lower limb, grade 0 power in right upper and lower limb, extensor plantar, absent cremasteric and abdominal reflex on right side, diminished deep tendon reflex on right side. Diagnosis: a case of acute stroke syndrome with dense right-sided hemiplegia and right human facial nerve palsy, possibly ischemic in origin, etiology, thrombotic in origin, involving left middle cerebral artery territory, possible site of lesion, left internal capsule, patient in neuronal shock with no evidence of increased ICT, no evidence of aspiration pneumonia.
Risk factors, you can mention. Risk factors.
Diabetes and hypertension.
70 years old age itself is a risk factor. Hypertension. Risk factor. Smoker, is a smoker. Diabetes.
He is hypertensive and diabetic, he doesn't have alcohol.
Diabetes and which type of what is the why diabetes leads to stroke? And that's what type of complications of diabetes are macrovascular and microvascular. Stroke comes under what category? Macrovascular. It's a macrovascular complication of diabetes. So have you look for any other microvascular complications? Someone with macrovascular is likely to have microvascular also. And then what are the microvascular complications of diabetes? Enumerate 3 microvascular diabetic complications.
Neuropathy,
Retinopathy, neuropathy, and nephropathy. How will you diagnose that? Your patient is having any of these. How will you identify? Retinopathy is postgraduate syllabus. How can you identify retinopathy? You have to play ophthalmoscope. Ophthalmoscope is postgraduate syllabus. Undergraduates usually don't. If you look through the fundus, you can examine the fundus using ophthalmoscope and look for changes of retinopathy. What are the other pathies you can diagnose? Neuropathy. What will happen in diabetic neuropathy? I am saying we also have diabetic neuropathy. What will happen? And here in this reflux was absent, you said, right? That was on one side or both sides? Can you show that slide? Reflux angle jerk. Two sides absent, right? Right and left angle jerk is absent. That is clonus, right? That angle jerk is present. Suppose the angle jerk is absent bilaterally, then you consider diabetic peripheral neuropathy or vibration. Sometimes you may get vibrations and touch sense, etc. Maybe there is a glove and stocking distribution of sensory loss. Okay, what about nephropathy? What is the symptom reported in patients with nephropathy? What is the symptom? There will be proteinuria. What is the symptom of proteinuria? Other macrovascular complications? Diabetes in this case. Does he have a CAD? Previous history of CAD? Exertional angina? Does he have peripheral pulses? Dorsalis present. Peripheral pulses, we have mentioned general examination or cardiovascular. You can mention the pulse rate and rhythm in general examination, but details the pulse like this, rhythm, character, peripheral pulse, everything you can mention along the cardiovascular system. So diabetes may be the main reason for stroke in this patient. Right? So is it possible for thrombolysis in this case? Regarding management, will you advise this patient came to you, will you advise thrombolysis?
Came after 9.
9 hours. So that is the importance of that 9 hours. Many patients will stroke when they get only this upper limb weakness, they will think it will go and disappear after some time, they won't consider it seriously. Whereas somebody will get chest pain means they immediately call the ambulance and go. Imagine that even a layman gets severe chest pain, what will he do? Chest pain means everyone is aware. People will get ambulance, go to hospital. But this somebody with the right upper limb only means he will wait for some time. Then after 3 or 4 hours only he is developing lower limb. And by the time diagnosed, when it comes to hospital itself, window period has passed. What was window period? 4.5 hours extended maximum. So thrombolysis period is gone. So CT, what's the importance of CT in this case? For thrombolysis, if the patient is coming in first 4 hours and you are planning thrombolysis, you have to exclude CT. Because bleeding need not always produce symptoms. Sometimes small bleed can be asymptomatic. Respiratory feature occurs only when there is a large bleed. Questions?
It's only related to the patient. The patient is progressing to the disease, the same patient. For example, 2-3 weeks later, what are the changes you are expecting? This I was mentioned for 1 or 2 points. What are the other changes can be expected? The patient is already on treatment. In the hospital, on treatment, the changes can be expected from the what are the findings the demonstrated now. What are the changes can you expect? Tone become increased, then can be exaggerated. That's a possibility. Then anything else? Plantar is extensor right side. Already extensor. That's going to be staying. Depends on the tonicity of the muscle can develop into clonus also. Then the power can improve. We are expecting these changes. Similar to the power also can slightly improve. Now most of the time if you see carefully, practically speaking, 0/5 throughout the upper limb from proximal to distal, less likely to have. So the practical tip, very less likely to have. Probably will be having certain parts of the body will be having 1/5. So just try to examine it carefully before committing that you got a 0/5. And one more point is dense hemiplegia means equal involvement of both upper and lower limb. Doesn't matter 3/5 or 2/5 or 4/5. It's equal involvement. It is not telling you the intensity of the weakness. You cannot say straight away for take it for granted, it's only a 0/5. It is not so. So the equal involvement. So that you try to fix the level of lesion, where exactly part of the brain is involved to explain the dense hemiplegia.
That's why I used the term disparity.
Yeah.
Upper limb, lower limb comparison. Both are grade 3 means is similar. 1 is 2, other is 4 means there's a disparity.
It's a very important look for. And which is the last sign you are expecting to recover for this patient? Because you are dealing with a nervous system involvement, upper motor neuron lesion, more specifically dealing with corticospinal tract, correct? Pyramidal fibers are involved in this patient majorly. Which is the last one to get recovered? Muscle power means is it proximal involvement or distal involvement? Of the involvement of any UMN lesion, specifically corticospinal tract involvement, which is the part of the body affected is going to recover at the last. Yes? Somebody is telling you about that. Fine skilled movements are going to be recovering last. So gross movements always recover a bit fast. The fine skilled distal movements always gets recovery at the last. It's not going to recover immediately. It means all these things are kept in mind regarding the therapeutic point of view. To be more aggressive on the distalmost point, especially fine skilled movement, that makes the patient feel that he is recovering completely. Even though you're going to reach 80-90%, the skilled, fine skilled movement to be therapeutically or physiotherapy, rehabilitation wise to be more aggressively involved. So the patient recovery feels, I feel as a patient, yes, completely recovered. If it's not going to recover, for me, proximally I'm able to lift up, comb my hair, but I'm not able to use my pen and to do the fine skilled movement, I feel like I'm not recovered. So satisfaction can be there if you're planning for or if you're knowing about the involvement and recovery process, the structure wise. If you're going to be more aggressive on that, it will be more useful for the patient. Okay? Yes.
Okay, so you have done reasonably good presentation. This is the way you expect candidates to present in the exam. Because you have to write an impressive case sheet. Once I went an examination, that candidate page is only one page. Yes, because I went to university exam and the university has given him 15 pages. In Kerala and all, the university booklet has 15 pages, 15 to 20. And he has written only 1 or 2 pages. So by seeing it itself, you will give only 1 or 2 marks. So you have to get an impressive case sheet. You should get a good history exam. This is the pattern you have to write other systems, diagnosis. So 2-3 pages you write history, then you examine the nervous system, then you examine other systems, negative history, general examination, diagnose you can write. So at least some 8 or 10 pages you have to write, then only the case sheet looks impressive. If you simply write 1 page, 2 page and all, the examiner that mark only will come like that.
The suggestion for investigation page is going to be customized or planned for focused investigation for that individual. Don't write starting from basic to advanced investigation, never try to do that. Similar to the treatment also. Suppose you are seeing a patient already established stroke. After 15 years, only for the sake of examination they have kept the patient for you. You cannot say thrombolysis, anticoagulation, all those steps should not be written. The treatment for that individual you have to plan. You should know the treatment, complete profile of treatment or armamentarium of the treatment, you should know that. But at the same time you should know which of that medication is applicable for this patient. That you have to write. Because most of the time what we see as an examiners, we always see complete investigations, complete treatment. Whatever is in the book, rewriting it. It is not expected. It is not reflecting your knowledge applied to that patient's problem list. Understand? So what do you think you will be planning for? So already sir has mentioned about thrombolysis is a bit of out of question. But anyhow you are going to see the patient in the emergency department. You are going to see this patient. Already we discussed one point, CT brain has to be organized. First I want to make sure that I am not dealing with hemorrhagic part. Okay, that you have done it. Vitals assessed, everything is done. And what is the next level of plan? At the emergency department and at the regular wards. Are you going to admit the patient in the intensive care or high intensity unit or going to be in the regular wards? Why? Each and everything has to be having most applicable for the postgraduate. You should know the reason for why do you want to admit the patient in which area.
Because he's already having a head.
See here the course, if you see carefully, progressed from lower limb, gradually progressed to the upper limb and face involvement or speech involvement is happening. So you might expect some anticipating neurological deficits. Might require intensive monitoring, not necessarily intensive care. High dependency unit also acceptable because vitals wise, every other aspect of the parameters are acceptable. Breathing, everything is okay. He is not having a respiratory compromise. He is not having shooting up of blood pressure to 220, 120, something like that is not there. So in that case, this needs monitoring. At the same time, I am not confident enough to admit the patient in the regular wards. So you can do that in the HDU, can be admitted. High dependency unit can be intermediate care, can be admitted. That's close monitoring. You need to monitor the vitals, especially for BP. Rhythm has to be monitored. Because mentioned about thrombotic and ischemic etiology. Either I am dealing with any irregular pulse, I need to closely monitor. BP also. Then anything else. Investigation wise. Good. Is a diabetic, you need to put for. How are you going to assess the intensity of the problem of diabetes? You are going to assess. It is not the static value of sugars. HbA1c also to be looked for. To know what was his, you mentioned about irregular treatment. To understand that, how much is the HbA1c level then? It's more than 10 years, why do you want to look for infections? Before they try to understand the per se, the investigation for the stroke part, investigation for the risk factors. So already you said about the patient is having diabetes for a long time. Make an arrangement for a fundoscope examination, make an arrangement for pulse other things examination. If you want to go for ECG, look for any silent MIs happening or not. That also could be there. But cholesterol can be requested, good kidney function including
For other complications
Yeah.
of diabetes like this nephropathy, urine PC ratio,
PCR ratio will be
yeah,
looked for.
there's, retinopathy. Is there any other neuroimaging other than head part? Any imaging techniques?
Is it angiogram
What is
or
a simple technique screening test for assessing the carotid arteries? You can do a neck vessel Doppler. Doppler, how much percent stenosis is indication for surgical? There is a surgery called carotid endarterectomy. It's more than 70% stenosis, so you can look for that.
up to 99%?
It is 100% means not treatment.
No treatment. 70 to 99%. So meaning that you should know the disease, try to understand both clinically, history and examination, investigation with intensity of the problem, what was the reason or risk factors for that disease, understand the complications.
Even the echo also, cardiac arrest, any other thrombus. Sometimes thrombus may be inside the heart, or there may be cardiomyopathy. So echocardiogram, death vessel Doppler, and CT head. These are the imaging studies. Will you be surprised if the CT is normal? If I am telling this patient CT, you tell at the end of this patient was brought in 9 hours. CT report came as normal. Will you blame the pathologist or no? Wow. CT, 50% cases CT is normal in first 24 hours. Infarct can be noted only after later. So what's the indication? Suppose there is a small infarct on first CT and 2 or 3 days later patient is deteriorating. This patient is becoming stuporous, he is developing seizures, he is getting altered sensorium. Will you do a repeat CT? What can happen in the repeat CT? Already you just saw an infarct in first CT. That is the point in taking repeat CT because we know there is an infarct. Infarct and there is something called hemorrhagic transformation of the infarct. For that you can do a repeat CT. Otherwise, if the patient is remaining healthy, there is no need for repeated CT.
Treatment is concerned, medications wise, assuming this is ischemic, thrombotic etiology, diabetes uncontrolled. Going to take care of the diabetes part. What about the stroke part? First drug thrombolysis we are ruled out. We are not planning for thrombolysis then. Antiplatelets. Name 1 or 2 antiplatelets. So in naming, okay? Whether to use it or not, I'm not discussing now. Antiplatelet should know. Anticoagulation names. Oral injectables. Anticoagulation injectables.
Traditional one.
Unfractionated heparin. Then you have a low molecular weight heparin. There are 2 anticoagulation. The point to be highlighted here is you should know the difference between the anticoagulation and thrombolysis. Both are not same. Okay? Yes.
There are situations where you prefer anticoagulation. All stroke patients you don't give anticoagulation. Routinely we give only antiplatelets. There are some specific scenarios where anticoagulants are advisable. Good. When there's atrial fibrillation stroke, then one more stroke I told that other than artery. When I told cortical paraplegia, I mentioned one thing like the venous sinus thrombus. That is, whenever there's a venous sinus thrombus, is indication for anticoagulation.
And diabetes part you have to take care of. That's also very essential. If you don't take care of the diabetic part, you worsen the stroke part. It's very important. Any stroke patient, the important therapy is rehabilitation. Whatever I try to tell about is medications, but very important is rehabilitation. Starting from feeds, calories, physiotherapy for the limbs, back care, urinary tract care, all those things are very, very essential part of a treatment of a stroke patient.
Day 1 itself you can start physical medicine. PVs and PMR consultation to physical medicine.
So this comprehensive way of knowing about this is very important. Write the case sheet. Never forget to mention about investigations and treatment. Okay, good presentation.